Our next guest is Dr. Angela Roberts. She is a speech-language pathologist with more than 20 years' experience working with adults who have cognitive and communication impairments, including individuals with Parkinson's disease. A former recipient of the Parkinsons Society Canada Graduate Student Award, she went on to success in other award competitions, including an Ontario Graduate Scholarship, a Queen Elizabeth II Graduate Scholarship in Science and Technology, and a Canadian Institute of Health Research Fellowship. And the reason why we mention those things is this part of what we do as the Parkinsons Society Canada is we help people get started in funding, in research, and as they begin to show some success, they're able to then gain a lot more funding, and we see it multiply. We were talking about that last night, the multiplication of your research dollars. So Dr. Roberts' research here focuses on the non-motor communication challenges in Parkinson's. So we're very excited to have her with us today. Would you join me in welcoming Dr. Angela Roberts?
Thank you, Todd, for that introduction, and thank you so very much for having me today. There are familiar faces that I met last night at the wonderful event that we had celebrating research, and new faces, and I look forward to getting around to meeting some of you today. A little bit different than what I talked about last night, which was more about research as from an overview perspective. Today, I'm going to focus specifically on the areas of research that I do, which really are changes in speech and communication, more broadly than just voice and speech, but really thinking about changes in communication in Parkinson's disease. And because I always promise to keep these talks as functional as possible, I've created some learning goals for you, and what you'll notice is the last item on that really are 5 tips. I promise that when you walk out of here today, you'll have at least 5 tips for taking home with you that you can implement today to help improve your quality of life from a communication perspective with Parkinson's disease. We've also talked a little bit about advocacy today, and that's one of the pillars that's being drawn to the forefront. And part of what I did yesterday, the talk that I'm going to give to you parallels the talk that I gave yesterday to healthcare, a telehealth rounds that we did yesterday for healthcare professionals in Saskatchewan. And part of the goal of that was really to teach the details of the therapies, the details of the interventions that I'm going to talk to you about today. So this really works from both sides. I educate healthcare professionals on how to work with people with Parkinson's disease and their care partners. And then I teach you what they should know so that you know how to go knock on their doors and say, you know what, I need help with this and I need this therapy and these are the skill sets I need for you to develop so that you can work with me. And then as a third arm of that, we had a brilliant kind of mid-afternoon tete-a-tete together with the Parkinsons Society Saskatchewan yesterday, talking about how do we now advocate at a policy level? How do we put things in place that allow healthcare professionals to get the needed training to work with you, especially on this notion of communication and speech components in Saskatchewan. So the talk I'm giving to you really is a component of that overall process around education and advocacy. So this is a bit of a thank you to my research partners, which span from Parkinsons Society Canada to a variety of other federal funding sources, as well as some of my collaborators and the graduate students who really helped to make this work possible. So we'll start by talking a little bit about what is communication. We all think we know what this is. We know it differs between men and women, or so that book, you know, women are from Mars and men are from Venus, or the reverse, or whatever the title was for that book. But communication really is essential to being human. Stephen Hawking once said, as a matter of fact, it is what makes us human. Communication is how we exchange information. So at a very basic level, it's how we transmit information from one entity to another. But it's also the primary mechanism around how we create, maintain, and change our relationships. And this is often the part that as we develop challenges in our brain that cause us to have issues with speech and communication, that cause us to have physical challenges, and we enter into these relationships that we euphemistically call caregiving relationships. But when we develop these relationships where we need help with other people, it's often this component of communication that gets lost. This component of communication is about maintaining relationships, because everything comes about in terms of, have you taken your medicines, have you done this, what are we doing today? It becomes much more that communication around messages and less about interaction. So we're going to talk today about how to improve some of this component of communication that allows us to maintain relationships. how do we communicate? Through a variety of ways, and we forget that it's much more than our speech and our voice, but we communicate with eye contact, we communicate through touch, we communicate through listening and hearing, and when we're talking about conditions such as Parkinson's disease, we really have to pay attention to all of these aspects of communication. We communicate through gestures, and we communicate through facial expressions. One of the more important ways in which, and so how many of you have had the experience of the words not matching someone's face? It would be like Barack Obama saying, "Man, I really love you," not with that face. And so one of the challenges that we have in Parkinson's disease is that it affects all of the different ways that we communicate. It certainly affects speech and voice, and caregivers also report that it's not just the speech and voice, it's that the content, the ideas that my partner is communicating just aren't as complex as what they once were. People with Parkinson's, and you heard me talk about this last night, this was the complaint from one of the patients that I worked with in the clinic that I worked in for years that actually drove me back to do my PhD. So it was that feeling that when they were engaged in conversation, they were lost in the conversation, not because at a fundamental level they couldn't understand what was going on, but because the time it took for them to understand what was going on. And that perception that by the time they put together what they wanted to say and process the information, that the remainder of the conversation had continued to move on without them. And so they had to make a choice. I can jump in with what I want to say, knowing that idea is already passed for everyone else, or I can just sit back and be quiet. And more often than not, people were choosing to sit back and be quiet. But as I said last night, physicians weren't asking those questions. People with Parkinson's didn't know that they could raise those questions. Family members didn't know that they could ask doctors about those questions. And I spent a full year talking to my clients and hearing other concerns such as, it wasn't the motor symptoms that kept me from being able to do my job. I stopped being able to find the words that I needed to use on a daily basis to communicate what I needed to. So this is the comment from a teacher that I worked with who said, everyone thought it was my tremor. It wasn't my tremors why I stopped teaching. I couldn't come up with key words that I needed when I was in front of my high school chemistry class that I'd been teaching for 25 years. That's why I quit working. I didn't feel like my communication skills could support me. And we weren't talking about this in the world of PD. We weren't talking about this clinically. It wasn't coming up in physician appointments. And I thought, we have to do something about that. So I went back to school, and this largely has become the work that I pursue. I'm going to give you a bit of an overview. In Parkinson's disease, the speech and voice challenges are most often what you hear about, and they're most often what we talk about. And in truth, changes in speech and voice really do affect about 80 to 90% of all individuals with Parkinson's. At some stage in time in the disease, you're going to have some changes in your voice, and those may be developing a quieter voice or clumsy or stumbling articulation. Some of your sounds just always don't come out the way you expect them to. A hoarse or breathy voice quality, or even changes in speech rate. So how many people in the room have experienced some changes in their speech and voice? And you see almost all the hands go up, and it's true, it's one of the ubiquitous symptoms of Parkinson's disease. However, what we haven't been focusing on for years is that all other aspects of communication are also affected. We know that there are changes in the ability to use gestures or the volume of gestures that people use to support their communication. We know that facial expressions are reduced and maybe not as animated as what they were prior to Parkinson's disease. We know that the ability to use the voice to convey emotions, that whether or not you're happy or sad or quizzical, the changes in voice inflection that we use often tend to be more leveled in Parkinson's disease, so some of that doesn't get communicated as well. It's like trying to communicate a humorous line and you wonder why your partner didn't get it, but maybe in part because that voice inflection wasn't there. Some of the more recent data that we have, which is quite interesting, shows that this isn't just a problem of expression. So we've often thought that this was just reduction in the facial movements, and this is what was causing some of these challenges. But it turns out that it actually is a core emotional component or emotional symptom of Parkinson's disease. This isn't just facial muscles and changes in facial muscles, because people with Parkinson's disease can also have some challenges actually processing emotions that are produced through facial expressions, particularly emotions such as sadness or anger. So if you don't have Parkinson's disease, you're well able to look at someone's face and determine if they're frustrated with you, angry with you, or if they're having an emotional shift. People with Parkinson's don't seem to be as sensitive to detecting those emotions through facial expressions. And what this means from a communication standpoint is if you are a partner, a communication partner of someone with Parkinson's, you need to make sure that your words match your emotions and not be fully dependent on those facial expressions to communicate it. You need to say what you mean as well as show what you mean. Language and cognition changes, these were virtually really unrecognized until really the last 5 to 7 years. And if I walk around the room, and I'll do that now, how many people would say you have trouble finding words? That tip of the tongue phenomenon that seems to be worse since you developed Parkinson's disease. Now, yes, indeed, I'll give you a tiny hint. Some of that's aging. It is. So there'll be even some Parkinson's partners in the room going, yeah, it happens to me. It does. I hate to say it is one of the very few ways, and I do mean that women are less, than men, because there aren't many ways that we're, less than men. But one of the ways that we have more challenges than men is around the time of menopause, females develop more challenges with finding words, and some of that's the hormonal changes that happen as a part of menopause. So some of this is a Parkinson's thing, some of it is an aging thing, but we do know that the difficulty people have in Parkinson's disease finding words is more exaggerated than what we see in normal aging. So this isn't just the same component as what we see in normal aging, and it does seem to be something about this chemical dopamine in our brain that becomes disrupted in Parkinson's disease that actually affects our ability to find the words, where you just get that, what we call tip of the tongue phenomenon. Individuals with Parkinson's disease they require a bit more time processing information. It's not that they can't process it, it's not that it won't be processed accurately, but sometimes, especially if there's multiple speakers in the room, it requires more time to process. And then one of the more common things that we're starting to see and understand a little bit differently is this notion of disruptions in speech, so increased pausing. So where you're actually going to talk and you may have these longer durations of pauses. Some of those may be word retrieval pauses, but we know it's this kind of confluence of motor components of speech and cognitive components of thinking and language components of finding words. Those pauses become particularly problematic in conversation because if you pause too long, your conversation partner jumps right in on top of you because they recognize that pause as being the gap in time where you're wanting them to take their turn. And so how many people have actually had that experience where you pause too long and someone jumps right in on you and you're like, whoa, I wasn't done with that. But that pausing time is a signal to your conversation partner that it's their turn. And so one of these challenges that we're working with in some of the therapies that I'm working on developing now in my lab are to do some help with reducing this pause time. So the discussion that I had with healthcare professionals yesterday, the discussion I had with some of you individually last night, the point of advocacy that I'll make with all of you today is that we really need to be thinking about our ability to communicate in Parkinson's disease from a much more global perspective. We need to get beyond thinking about just speech and voice and being loud. We all know, and I'll talk about that therapy, that being loud is really important, but there's much more to communicating in Parkinson's disease than just being loud. Because I can be loud all day long, but if I still have 6, 7, 8 second pauses in my communication, someone's still going to jump in on top of me. And so we need to be thinking about, from a therapeutic perspective and from a strategy perspective, ensuring that we are working on communication as a whole approach. And that means that we have to combine approaches. There is no such thing as a cookbook approach to working in Parkinson's disease. If I went around this room, each and every one of you has a different symptom profile. Your experience is not like the person sitting next to you, and that can often cause challenges with people with Parkinson's. They want to know, my disease isn't like Joe's disease. Why is that? Well, it's because how this chemical dopamine is lost in the brain, how these structures are affected, is not the same across two people. And so what that means is we need to combine approaches, and we need approaches that are adaptable over time. One of my little micro points, I am a rather political person, I do have to tell you that. I am an advocate for people with Parkinson's disease, and I do believe in telling their story beyond my own research that I do. And one of my big advocacy points these days is that we have a role as healthcare professionals, as rehabilitation therapists, at every stage of living with Parkinson's disease. That from day one to the very last day that you fight that battle, we have a role with you. The problem is, what our data shows is that healthcare and rehab professionals are really only called into the care of people with Parkinson's disease in a very narrow window, and that's about stage 2 of the disease. After that, it seems like we don't quite know what to do. Before that, we don't really have the educational resources to provide to you. And really and truthfully, the medications that we have are tremendous, but they only fill a certain gap of the symptoms that people live with Parkinson's disease. And so it is these behavioral therapies that help to bridge that gap. And so part of what I'll present to you today really are a coterie of therapies, a toolbox of therapies and interventions that can be combined across the duration of Parkinson's disease to help people live a more full and rich life. So this may seem a bit odd. And I will, by point of disclosure, tell you my husband is an audiologist. That's not why this slide is here. But it's because he did raise my awareness to the fact of just how important it is. So when we're talking about communication, there are some of us who more often than not sit in a room and talk to ourselves. I am one of those people. If you watch me in a restaurant, I can be having a conversation with myself in my head. My husband often reminds me not to wave my hands at myself and to let people know that it could be dangerous for my career. However, most of us, when we're communicating, are communicating with someone. We're having an interaction with someone. The problem is that interaction can often be affected by not just your own skill sets as a speaker and as a listener, but by the other person's skill sets as a listener and a speaker. So hearing changes actually begin in our 40s. And so unless I'm mistaken, there aren't many people in this room under the age of 40. I could be wrong. But that means that all of us to some degree have already started having changes in our hearing. And one of the major changes that happens with age is hearing in noise. So if we just do threshold testing on you, you come out normal, but your ability to hear in noise, and there's special tests that audiologists can do to discriminate that, and that becomes really important because that's a skill that's needed for speech. So if you take the voice changes that occur in Parkinson's, which I already told you were quieter, more pauses, more word retrieval challenges, and you put that with a partner who now has a hearing loss, even a very mild one, then you get a lot more of this. Can you speak up? You need to go have your hearing checked. So how many times has that been said in your house? A few of us have probably had that uttered. And so we did this little bit of a project back a few years ago where I do a fair amount of these talks on the road, and what we did was test the hearing of everybody in a room this size. So let's say we took 4 talks with this many people in the room. We tested everyone's hearing. 65 to 70% of the caregivers, the partners of people with Parkinson's, had hearing loss, substantial enough to affect communication that they did not know about. About 40 to 50% of the individuals with Parkinson's disease did. So when your voice is crying, and that's typically when I see spouses and communication partners turn to each other and say, "I told you." It's not me, it's you. Well, sometimes that's actually true. Sometimes it is this combination of the changing in voice, changing in speech, changes in language, and also in changes in the hearing. So now I kind of have this rule. When people come to see me as a dyad, whether that is your best friend Bob who comes with you or your spouse who comes with you, everybody's going to get their hearing checked. There's another reason for doing this. One, hearing loss is the 3rd most common condition in people over the age of 55. So it's more common than heart disease, it's more common than high blood pressure. The recommendation is that people have their hearing checked every 2 years. And we really focus on this because of the fact that there's so much that we can actually do to support hearing these days. Mm-hmm.
Does gender have anything to do with it?
I will answer that question briefly. We used to think gender had a lot to do with it, and there's a recent set of studies actually done by the same group here, Dar and Siegel, who actually show now there's no differences in hearing as a function of age. So a year ago, we probably would have answered that question, yes. We now have definitive data from about 4,000 people who say that's not true. So it's not a gender thing. We can't blame that. It would be nice if we could blame that, but it's not. It really is just an age thing. And so the other thing can happen with hearing changes, even very subtle hearing changes, that the amount of resources that your brain has to use to now listen get taken away from other things like being able to make your speech loud enough and being able to find, retrieve words and keep your train of thought. So this notion around hearing is much more than just, can I hear you? It's also what the brain is able to do with the resources that it has. So whether you're an individual with Parkinson's or a care partner of someone who has Parkinson's, it's important to kind of follow this first tip, which is to get your hearing checked. The second thing that, my second tip to you today is speech and voice therapy. Now, I am completely aware that there are limited resources. There are everywhere. And so I'm going to cover a variety of therapies today, some that are more dependent on working with a speech-language pathologist or speech-language therapist, and others that are a little bit more independent that you can actually work on at home. Okay, so I'm going to give you a variety of strategies to use today. There's two basic approaches that we take. One are therapies that just increase loudness. So those are therapies that are just really focused on helping to make the voice louder. They do, as a result, end up also making speech slower because it's really hard to be loud and fast all at the same time. If you've ever tried, it doesn't work really well. So by increasing loudness, we by consequence reduce rate. However, one of the challenges is that the gold standard therapy that we have, a therapy called Lee-Silverman voice treatment, has to be done by a certified therapist. And there aren't very many certified therapists in this program. And I'll tell you a little bit about some things that are changing from an advocacy point around that. But the second therapy that I'm going to show you today is something called clear speech. Now, clear speech we've had around for many, many years. But a recent set of articles out of Chris Jaden's lab at the University of Buffalo over the last 2 years has shown that it may be just as effective as increasing loudness. The benefit is it doesn't require a therapist who's certified in the therapy, so any speech-language therapist can do this program with you, and you can actually really practice it at home on your own fairly well. So its focus is not necessarily getting loud, but really thinking about exaggerating what we call articulator movement. So exaggerating the movements of your mouth, your tongue, your respiratory system. So thinking about making your speech extra clear. And before you worry about what that looks like, we're actually going to practice that here in a couple of slides. I'm going to let you know, get ready to kind of move around in your seats because I'm going to actually make you work here in a few minutes. So the Lee-Silverman voice treatment has been around for 20 years plus. It has the most evidence of any field. It was a therapy developed specifically for people with Parkinson's disease. Has anyone actually had the Lee-Silverman voice treatment in the room? A couple of people. It is an intensive exercise program, meaning that the typical program is 4 days a week for 4 weeks. That can make it very challenging for some people to get to. It is a systematic approach for recalibrating loudness. And this is important, and I'm going to take just a brief moment to tell you why. So the issue in Parkinson's disease around speech and voice isn't muscle weakness. The muscles for speech are not weak. They are just as strong as someone who doesn't have Parkinson's disease. Even the respiratory muscles, the breathing muscles are. The challenge in Parkinson's disease is what we call a scaling disorder, meaning that the muscles don't know how much movement they need to make or how much they need to contract in order to make the voice loud enough. So what happens is the brain almost establishes this lower threshold for how loud is loud enough, how much movement is enough movement. And so these therapies, LSVT as well as clear speech, are really directed at changing that threshold a bit, changing that brain's level of what is loud enough and what is large enough in terms of movement. And that's how they work. The issue is LSVT works great on the people for whom it works well for, but it doesn't work for everybody. And this can be quite a frustrating point for people. It in particular doesn't work so well for individuals who are starting to have some cognitive changes. Now, we know that changes in cognition or thinking skills are present in about 30% of all people from the very first day of diagnosis. But these are minor. They're minor changes that you may notice, but other people around you don't notice. But as these challenges become a little bit more severe in terms of bordering on what we call mild cognitive impairment or an early dementia, then therapies like LSVT don't work as well. However, there are a couple of points about this therapy. And again, all of these things change. 3 years ago, had you heard me give this talk, I would have said, I don't think LSVT is best for everyone. And I actually kind of put it on the back burner of therapy choices because the truth was it's a great therapy, but not very many people have access to it. But the folks at LSVT have done a lot of research over the last several years to try to make this therapy more accessible to people who have Parkinson's disease. And one of the things that they've done is actually to modify the intensity. So instead of 4 days a week for 4 weeks, it's just as effective if you do it 2 days a week for 8 weeks. Now you may wonder why I'm telling you this, because this is the same slide that I gave to the speech language therapy group yesterday. I'm telling you this so that you have the knowledge in your hand when you meet with a speech language therapist to say, you know what, 2 days a week works better for me. I know it's just as efficacious. I can prove that. Here's the slide. Now let's do something that works for me. Right, so this really is about putting power in your hands as individuals living with Parkinson's disease and as care partners advocating for people with Parkinson's disease. The other thing that's now available is an online training. So speech language therapists no longer have to go to Boston or go to Colorado or to go to Europe to be trained in this therapy. They can actually do the course online, and that becomes really important. And we talked yesterday about how we might utilize funds and in terms of funds that people want to donate to help support speech language therapists to get trained in this therapy so that they can support you, people in the communities here in Saskatchewan. The other new thing with this therapy is that we now know it can be delivered just as well using telehealth, so over a computer or an iPad, as it can be face-to-face. So this is huge for where I live, where I service a lot of people in Northern Ontario who there's no way, to get to see me is a flight. So they are not flying in 2 days a week. They are not flying in 4 days a week. They're not going to be able to do this at all. But what I can do now is use an iPad or a computer to treat them online. And so this becomes a nice way for us to think about modifying. I'm a real big believer that it's not that we don't have solutions, we just need to develop creative solutions, and this is one of the ways that we're trying to develop creative solutions to get care services out to people in communities. But now I'm going to talk to you a little bit about this therapy called Clear Speech, because Clear Speech is a therapy that you can do all on your own. And it really is thinking, it's this simple. You can develop a series of 25 to 50 sentences. Why? Because you need a lot of sentences in different contexts to practice on. You can read each sentence aloud 2 times each, and the only thing you have to think about when you're reading is, I'm going to read this sentence out loud twice as clear as my typical speech is. That's it. And that twice as clear comes from, if you remember the old-fashioned days of elocution, how, now, brown, cow. I know, right? I have to, and then I remember typing that phrase when I actually learned how to type, not on a computer. So this notion of really exaggerating your mouth movements, your tongue movements to make clear speech. So we're going to practice this. The first sentence is, today is a wonderful day. So everyone kind of gets situated in your chairs. Always be mindful of your posture, so you want your back to be straight as you can. Take a nice deep breath and really exaggerating your mouth movements, exaggerating your tongue movements, even if it feels very strange to do that. On the count of 3, I want everybody to read the sentence, today is a wonderful day, in speech that's twice as clear as what your normal speech is. Okay? 1, 2, 3. Good. Now one more time and really exaggerate. Stretch your mouth, stretch your tongue. Even if it feels weird, go ahead and do that again. 1, 2, 3.
Today is a wonderful day. Wonderful.
Excellent. Now let's try this one. I am surrounded by friends, because you actually really are. All right. Now, again, even more so than before, because I'm watching at some of you, and based on looking at the first sentence, your second sentence was more exaggerated than your first sentence. So let's try this one. Twice as clear, twice as exaggerated as your movements would be at baseline. Ready? On the count of 3. 1, 2, 3.
I am surrounded by friends.
Much better. And one more time, because we do each sentence twice. Why? Because we're redundant and I'm slow. Go ahead.
I am surrounded by friends.
Good. Now, if you're someone who doesn't have Parkinson's, that probably felt a little strange to you. But believe it or not, if you're someone with Parkinson's, it probably felt more strange. Do you know what it looked like, though? Normal. And so one of the things that we have to be thinking about with Parkinson's, remember I said this is a scaling issue. So did you feel like you were louder? If you're someone with Parkinson's, did you feel like you were louder when you did the twice as clear? A little bit. Did you feel like your speech was slower and more clear and more articulate? And so this is how this therapy works. And the reason for doing the practice every day, and some of you were like, yeah, so immediately with 2 sentences you can go, wow, that felt different and it sounded different. I know I sounded a little bit more like myself. My speech sounded more clear. My speech may or may not have sounded louder, but it felt easier to understand. The reason for practicing every day, and I'll drive this point home again, is we have to recalibrate the brain. You have to recalibrate the brain to what feels normal. And I will tell you, when you first start practicing, whether it's increased loudness or whether it's something like the clear speech strategies, it feels very strange to you. You feel like you're shouting. You feel like you're stretching your muscles to all ends of the world, and it must look very strange, but it really doesn't. I'll tell you, looking at all of you, and I can, after doing this a while, I know who has Parkinson's and who doesn't have Parkinson's in the audience. You looked great. You looked really great. And so it is a therapy that you can do on your own at home. It's helpful if you have a speech language therapist to help you, but you can take these sentences, practice them every day for 10 to 20 minutes a day, and it helps to recalibrate your brain's level. And again, the focus is hyperarticulation, hyper or extra movement of those muscles. So I'll go over some home practice helpers, some things that will help you when you're practicing at home. Sometimes we suggest using actually a sound level meter. You can get these for about $40 or $50. They're not that expensive. The typical voice volume that we're looking for is between 60 and 70 decibels, and it just gives you some feedback at home about how loud your speech is when you're practicing. You can also get feedback from others, and that's really important. So I'm not sure whether partners of people living with Parkinson's realize just how weird it feels when people with Parkinson's start to make their voice louder or start to try to make their voice more clear. Because again, you have to remember the brain's threshold of what is normal has shifted for them. And so oftentimes the very first thing that I hear is, I feel like I'm shouting. I feel like my mouth is just, this isn't normal, because the perception is that it isn't normal. So as partners of people with Parkinson's disease, whether spousal, grandkids, or friends, we have to reinforce to them that, you know what, it may feel strange to you, but it actually looks good, and it sounds good, and it sounds like you used to sound. And so providing that feedback becomes really important. And if you're someone with Parkinson's, allowing someone to give you that feedback becomes really important, because you need to anchor your performance by their ear. Because you have to remember, your brain is playing tricks on you. Your brain is telling you that you're loud enough when you're not. Your brain is telling you that the movements are large enough when they're not. And that's something that you're not going to change except for with a lot of practice. There are a couple of apps that we use, so those people who are more technologically savvy than others, so you can download these to a smartphone or to an iPad. This one is actually a free one that comes from the Northwest Parkinson's Society in the US, kind of on the Pacific coast. And it allows you to watch yourself as well as listen to yourself, and it gives you some practice sentences and phrases. And these are all virtual sound level meters. So I don't think you have the slides in the packet, but I will make sure that they're available to you from Todd and those guys. So you don't necessarily have to write all of this down. I'll make sure that you get those links for those apps. But this one in particular is a good one. I use it a lot, and as I said, it is free. So my tip number 3 for the day is that you consider using devices. And so this gets into that approach that I was saying, not everything works all the time. And we do have a couple of devices available for people with Parkinson's disease. Some of them are voice amplifiers. So these are just devices that, when needed, make your voice louder when you've tried everything else, and when it's just a bad day or a bad moment or a bad hour and you can't make your voice loud enough. This is a tiny, it's almost like a mini PA system that you wear, and it helps to make your voice loud enough to be heard for others. I've given you a list here from a study that we actually did at the University of Western Ontario. One of our graduate students did with Professor Scott Adams. It actually looked at having people with Parkinson's disease rate these devices as well as their care partners and which one worked better than others. There's a lot of these on the market. They are funded by the Assisted Devices program in most of the provinces, and so for most people with Parkinson's, you can actually get one of these paid for. This is a different way of amplifying the voice, and it's one that we've been using a lot of late. I do, as well as my colleague, Dr. Scott Adams, does. And this, again, was inspired by my beautiful audiologist husband, because this is a classic device that's used by audiologists as a supplement or an alternative to a hearing aid. What it actually does is the person who is speaking wears the transmitter, and the person who is listening wears the receiver. So you might notice that one of the advantages to this device is there's no microphone in front of the mouth. There's no speaker that the person wears. They're incredibly lightweight. They weigh about 3 ounces. They're not very heavy at all. And the person who is listening actually wears a tiny little earbud, sometimes an actual loop, and that's what transmits the sound. So this gives a lot of options. You know, even if you have a voice amplifier on, you really need to be in the same room in order to have that communication event. This actually lets people be in 2 different rooms in order to be heard. And it works rather well. The sound quality is quite good in them. They range in price from around $400 to more expensive options. If you already have a hearing aid, this is something that can actually be ordered as an accessory to a hearing aid. So if the conversation partner already wears hearing aids, it can be ordered as an adaptation, and it can be used in absence of needing a hearing aid. We've used these in a variety of ways. I have an attorney who uses one when he's in the courtroom, because if there's 30 people in the courtroom, you know, in terms of jurors and court staff, each one of them can wear one of these receivers and set the intensity that works for him or her. So it's not my client projecting from the speaker that he wears. He's actually talking directly into their ear, so it allows him to still be in the courtroom successfully when otherwise he wouldn't be able to. The clients who actually taught us the lesson that these worked were a gentleman and his father who were taking a road trip from London out to Vancouver, and they needed a way to communicate in the car, because with all the car noise, they knew that my client with Parkinson's disease couldn't be heard by his father who had a hearing loss. We tried this with them and it worked brilliantly. And then we thought, maybe that would actually work well for others. And so this really has become a bit of a mainstay for us in terms of voice amplification. This is a device I'm going to introduce you to, and this is a bit of a Cadillac device, I'm just going to tell you. But it is probably the most exciting technology to come around for people with Parkinson's disease in a very long time, especially relative to speech and language. It's a device that received its Health Canada approval earlier this year, so it is available in Canada. But it comes out of the lab of Dr. Jessica Huber at Purdue University. And it's a device called a Speech Vive. You might notice it looks a little bit like a hearing aid. The person with Parkinson's disease wears this. It's what we call a non-occlusive fitting, meaning that it doesn't block the ear, so it doesn't affect your ability to hear. But let me tell you a little bit about what it does. It's based on a theory that we call the Lombard Effect. What the Lombard Effect is the tendency to elevate your voice in crowd noise. So it's that notion that whenever we're in a noisy room, we try to elevate our voices so that everyone can get above the background noise, consequently making the louder environment even louder. But what we know about people with Parkinson's disease is, although the degree to which they can raise their voice is less, the actual brain reflex that causes us to do this, that causes us to raise our voice above the background noise, is actually preserved in Parkinson's disease. It's not affected at all. So when people with Parkinson's disease are in background noise, they do push their voice more. It just may not be the same amount as someone who doesn't have Parkinson's disease. So what this little device does is actually senses when the person with Parkinson's disease is talking, and when they're not loud enough, it actually plays a little bit of this crowd noise, multi-talk or background noise, into the person with Parkinson's ear. Immediately, automatically, without the individual with Parkinson's even thinking about it, it elevates their voice volume. You don't have to try to do anything. It just makes you get louder. It helps you to get louder, and it helps you to get slower, because as I said before, you can't be slow, right? You can't be fast and loud at the same time. So this little device, and before you say, oh my gosh, that would drive me nuts, actually I've seen it in operation with a lot of people now. It doesn't drive you nuts. You get used to the fact that it's there, and it actually makes a huge difference. You put it on someone, and instantly, as soon as you set the thresholds and turn it on, all of a sudden you have this person who sounds like they sounded before they had Parkinson's. It's a pretty impressive technology based on theory that we have known for a long time. I did have a video clip to play for you, but we don't have any audio attached to my computer, so I'm not going to be able to play it for you. But I'll go over a little bit about some of the results that they have found. So with this device, 90 to 95% of all people wearing it have an improvement in some way, either with reduced speech rate or with increased loudness or increased voice clarity. 75% of people increased their loudness after wearing the device for a month, and then even after they took the device off, half of them were able to retain that loudness level. So that's pretty impressive. Wearing the device for several hours in a day, 6 to 8 hours a day, over the course of a month, you can actually take the device off and go without it. People who wear these devices will say, you know, occasionally I notice my voice is getting quieter again, it's not as strong. I put the device back on for 3 or 4 days, and then I'm right back on target. I can take it off again. So one of the reasons is that calibration thing I was telling you about, that notion of resetting thresholds. And that's actually what this does. When you've worn it for long enough, the brain develops a new threshold of what is loud enough, what is clear enough, what is slow enough to be understood. And then it gets this new baseline. So that is how the device works. It is an ongoing device in that you don't ever, what we know is that people don't habituate to its use. You would also think, well, if it's, you know, if I have it on all the time, I'm going to get used to wearing it, and it's no longer going to work. It doesn't. The data that we have 3 and 4 years out shows that people don't actually habituate to the device. It continues to work as long as they continue to use it. So this is the other thing we kind of talked about in our little head meeting group yesterday is how, and I talked to this a lot with the rehab professionals yesterday in terms of getting their skill set ready for this, learning how to use these devices. Our advocacy points in terms of advocating with the ministry to actually cover this device, it is not inconsequential in terms of its cost. It's about $2,400, so I won't lie to you. However, that's about the same cost, I'm told, for a private therapy session for LSVT, for a course of LSVT, if it's not covered by the ministry and you're getting that from a private practice therapist. So the cost may not be that different from a course of therapy here. But it has long-term effects that aren't going to lose their effect. This is also a really beneficial therapy for people who are starting to have cognitive challenges because, again, they don't have to think about being loud or remember to be loud. The device itself just triggers this automatic reaction. So it's something to think about. It's something to watch for, and I'll certainly continue to advocate for you throughout the province of Saskatchewan as well as the other provinces that I do work in. Continue to advocate with Parkinson's Society Canada about ensuring these technologies are available for you. So my tip number 4 for the day is exercise. Now, I don't have to tell anybody in this room that, right? Everybody exercises on a regular basis. Yes, right. Everybody except me, right? Let me tell you about the life of a researcher. We sit at our desk much more than we do anything else, so it's I often need reminding of this as well. But why would I say exercise relative to communication and to language and to speech in Parkinson's? Because I'm exercising my arms and my legs. I'm not doing anything for my speech when I do that. But the truth is that individuals with Parkinson's disease, and I hate to say this, I always hate to be the bearer of bad news, so I'm going to couch this in very gently. People with Parkinson's disease are at a 6-fold increased risk of developing dementia over people who don't have Parkinson's disease. That's just a fact. And even if it's not dementia, developing some form of what we call mild cognitive impairment. So that can certainly have a negative impact on communication because on top of them, the speech issues, the voice issues, the language issues that we see change in Parkinson's disease, we get these other effects of dementia. So one of the real benefits to exercise in Parkinson's disease is it reduces the risk of dementia. So it reduces the risk of dementia in the basic population. It also reduces the risk of dementia in people with Parkinson's disease. But we've also got some very focused studies by Cruz and Nachera who tell us that not only does it make you physically stronger, it helps with mood, it helps reduce dementia risk, but it actually does improve language. So people experience fewer word retrieval issues when they're doing regular exercise programs than they did prior to starting those exercise programs. So it does activate brain pathways that support speech and language as well. In terms of the type of exercise that's best, there is no best form of exercise, I will tell you that. A lot of my researcher colleagues say, well, it's weights, and others say, well, it's doing the bike, well, it's running. It is the exercise program that works for you. What is important from a cognition standpoint, so not necessarily from joint mobility for Parkinson's or walking, but from a cognitive standpoint and a dementia prevention standpoint, what is important is that it needs to be at least 20 to 30 minutes at a time when you're doing it, several days a week. It needs to be able to elevate your heart rate, what we say is to about 60 to 70% of your maximal heart rate, or even a little bit higher, and that should be done with your doctor's oversight. And that you typically need to exercise about 6 to 12 months before we see that maximal effect on cognition. So whereas we don't say that there's any one exercise program that's best, we do know that how you exercise makes a difference for this reduction risk. And a lot of the exercise programs that we do offer often are great stretching programs, but they don't necessarily do this. They don't necessarily get the vigorous heart rate elevations that are necessary to mitigate dementia risk. So one of the last tip, I promise I said 5, so I'm giving you 5. Do you guys all feel like you have something you can take home with you as of yet? Okay, oh, phew, that's good. So the 5th one that I'm going to go over with you today, and then I'll open the floor for questions, really is increased social interaction. So physical exercise is tremendous in terms of reducing the risk of cognitive decline, but what is almost just as powerful is social interaction. We know that there's a direct relationship between social isolation and the development of dementia in Parkinson's disease and in other populations. However, one of the first things that happens when people have Parkinson's disease is the extra mobility challenges, the communication challenges. They start backing away from the activities that were important to them, the activities that kept them social. You may not be able to keep up with the same turn sequence in bridge or the card game group that you were a part of, and so because you can't perform at your previous levels, you pull away from those. And those are all forms of social isolation that contribute to the development of depression, other mood issues, as well as cognitive issues in Parkinson's disease. So in addition to exercise, probably the most valuable form of cognitive stimulation we have. Now, I love all those computer games, and I think it's great if you want to brain quest your brain out till 3 o'clock in the morning, and that's what you want to do, playing all those kind of computer games that stimulate memory and are supposed to help you with attention. But I will tell you what the evidence shows us, they make you good at playing computer games. They don't necessarily affect memory and thinking skills in functional tasks. Social interaction does. It lets you practice. You're constant. Anytime you're in a social situation, you're talking, you're listening, you are firing brain pathways like mad. And you're doing it in a context that's actually meaningful, that your brain recognizes as being meaningful. So it's a substantial amount of the work that I do in Parkinson's disease is now on therapies, because in my world, in the speech language therapy world, we don't actually talk about communication or conversation-based therapies at all. We work on your speech, we work on your voice, that's it. We don't do anything beyond that. And the therapies that come out of my line of research work really are on designing these conversation-based therapies. And let me tell you about how they're different. They really are about teaching compensatory strategies in a systematic way that allow people to maintain social interaction and that help partners facilitate, and people with Parkinson's disease facilitate their own communication. It's about balancing the burden in conversation between you and the partner, so someone's not having to work so hard to listen or to disambiguate the message. And so the approaches that we do are called conversational therapy approaches or conversational coaching. And what this means is the person with Parkinson's disease isn't the only person in the therapy situation with me, so is their partner. That partner can be a spouse, that partner can be a friend, that partner can be a grandchild. But I don't work with a person with Parkinson's disease on their own. It's always in what we call a dyad, or a two-person exchange. And these are some of the strategies that we have taught over the years. I'll go over them briefly with you, and again, I'll make sure that you have all of these slides. These are the ones that we find useful and that the people that we work with Parkinson's find useful, their care partners find useful, and it comes out of really listening to them and doing some of the research that we do. But the first one is to reframe your communication expectations. Don't expect someone to be loud all the time. Expect that there's going to be delays. Expect that it may take them a while to process information. And really focus, take the time to focus sometimes on just the social engagement and not necessarily the message accuracy. If someone flubs up on a word or they're not loud enough, don't use that as a moment to test them or to correct them. Just acknowledge that it was a useful moment of engagement where the two of you had the chance to connect in a conversation moment. And that becomes really important. To make sure that we give extra time, we need to be patient listeners. We need to allow for that extra time in processing. We need to slow conversation down so it's not two. It's you take a turn, I'm going to wait, give you the chance to formulate what you want to say. And people with Parkinson's disease also need to understand it's going to take them more time. And so not to back away from the conversation exchange, but to give a signal that says, you know what, I need more time. Give me just a minute, I'll get my thoughts together. So that everyone around you knows that you're going to come up with the word. You just need a few more minutes to do that. We like to say to focus on the prime opportunities. This means that if you have a really important conversation to have, don't do that when someone's in off state, because their brain won't be working well, they may be in more or less pain, they're having more trouble moving. So choose the times that you communicate wisely. Reduce distractions. This means that you can't have an important conversation while someone's washing dishes and the other person's watching the hockey game. That's not going to work. Turn the sink off, turn the television off, get face-to-face, knowing that everyone needs more resources to communicate. And then creating opportunities for shared frame of references. And I'm just this gets to be a little bit more intimate point, but how many couples have noticed that just the activities they engage in have changed? I don't mean to make this couple focused, but it kind of is a question relates to that. That the activities that you're involved in change since one of the partners has developed Parkinson's disease. And I always see the heads kind of shake. It's important to maintain and to now existing activities, but also to create new activities that you both can enjoy. It's really hard to have social engagement and interaction if you don't have anything to talk about. And so if some of those activities have changed, learning how to create new activities and new interests that accommodate both partners' needs. Filling in information is a valuable strategy, but you've got to create rules around it first, and I always encourage partners to do this. It gets very easy when we sense that our loved one with Parkinson's disease is pausing or can't come up with a word or can't be understood for us to just say, well, what he really meant to say was this, or I know he's looking for this word. All that does is actually interrupt their thought processes. So you need to create some rules of engagement with this. I want you to help me, but when I let you know it's time. And you can signal to your partner, I need a little bit of help now, and then that's your turn, that's your cue to come in and say, what John was actually trying to say was that we went to the doctor yesterday and he had a change in his medications. So it becomes important not to just fill in unless you and your partner have an arrangement to do that, and that you do establish those rules of engagement to begin with, but it can be a very helpful strategy. We want to always be alert. You want to remember that people signal their communication attempts both verbally and non-verbally with words and with facial expressions, and you want to watch for those opportunities. You want to make sure that before you move forward in any context, you make sure you've understood correctly. Did I understand you correctly? You want to go to, I don't know, a common grocery. You want to go to Walmart at the end of the day in order to get some new fishing tackle. Before you move forward, if you don't think you've understood what someone has said on either partner's role, whether you're the person with Parkinson's or a conversation partner, you want to verify that you've understood. You want to clarify that you've understood before moving forward. So some of our take-home messages today is that communication is complex in Parkinson's disease. I hope you have a greater awareness of that. I hope as partners you go, wow, now I actually understand a bit more. I hope as someone with Parkinson's you go, now I actually understand myself a little bit better. I know those things just aren't me getting older, just aren't nuances of me. They actually are part of my disease. And we want to be flexible and use a combination of approaches that may include anything from therapy to devices and to social interactions and exercise. And so lastly, my great big thank you to Regina. This was my first trip to Regina. Some of you know it was my first trip to Saskatchewan. I have had a tremendous time. I said to my husband last night, and I want to take just a minute to, and I know I'm getting into my question time, I do realize that, Todd, but I want to take just a minute to say, I said to my husband last night, I have worked across Canada for people with Parkinson's disease. I have worked with a variety of Parkinson's support groups. I have never been as inspired as I have been the last 2 days, and I will say that with full honesty. There is an integrity and an industriousness to people who live in this part of the world. I have no doubt that you can accomplish anything and everything for each other. And that is a very sincere compliment on my part, and I thank you very much for letting me have the opportunity to be here with you. Want to do questions now? Okay. So I'm happy to take questions now. I'm going to maybe encourage Todd to grab the microphone or Michelle to grab the microphone just in case someone has a bit of trouble. Feel free. It does not bother me if you need to now move and go out and get a break. I recognize I went a little bit over. I apologize for that. But are there any questions that I can answer for people about the strategies that I went over or how to implement them at home, or just questions about Parkinson's disease in general?
When you're conversing with someone on the phone and you don't understand or hear what they're saying, what do you suggest as being helpful?
Yeah, telephones are particularly problematic because we don't have the visual, right? We don't have, there's a couple of things. Is it a voice loudness problem? Is that the challenge that you're having, or sometimes that you're having? Loudness and clarity. So loudness, one of the ways to take care of loudness is actually to get a telephone that amplifies the outgoing signal. And those are pretty reasonable to pick up. They'll run about $120. You can get them from most of the Canadian kind of resource facilities for people with hearing loss, and they exist across Canada. I can look into that and probably send you an exact contact. You can also buy them from Amazon and a whole host of places. But what that allows is that the person on the other side who has a softer voice, we can actually get about 10 to 15 decibels of increased volume just by using one of those phones. But it has to be, there are phones that have both incoming for people with hearing loss. You have to make sure it's a phone that has incoming and outgoing amplification of the signal. So that's the one thing I would suggest. There are certain devices like the Speech 5 device that would take care of that for certain, no matter where somebody was. And then one of the other options is just to, again, use some of these conversation strategies. You know, I'm sorry, I didn't understand you. Did you say that you needed me to come over? And then that gives the other person on the other end of the line a signal to say, no, I didn't say come over, I want to come over. You know, I didn't want you to come over, I want to come over. So what that often happens when you trigger someone to repeat themselves, what that often sends to us as a human communicator is a signal that I need you to slow down and I need you to try that again. So I would suggest, at least on a cursory level, without knowing the exact situation, thinking about a device solution in terms of amplification, and also thinking about doing some of that checking back and verification. You may have to do that quite often in the conversation, but it at least ensures the messages are coming through loud and clear. What will also happen is the more you do that clarification, you'll get a better idea about what the context is overall that that person's talking about, which will make you a better guesser of what they're actually saying. So you may find that you have to clarify less as the conversation goes on. Yeah.
So the new Cadillac device that Lombard Effect, I think you said?
Yeah, it's called the Speech 5, and it optimizes a theory called the Lombard Effect, yeah.
Okay, so is that available in Canada? Is it?
So we need to get some training for our speech language therapists. So it does still involve a speech language therapist in that it is available in that I have one, but mine is largely in a research capacity at this point in time. There's no reason why it can't be available here, though. It does have Health Canada approval. What we need is to put some advocacy in place to get our speech language therapists trained in how to use the device. So because there's no reason why it can't be available in Canada. What we have a lag in now is just getting the training. It's been out in the U.S. solidly for, you know, probably a year to 18 months now. It's just kind of come to Canada, so I think we're starting to see, I'm doing all that I can to get information out about the device. So maybe about just talking with the speech language therapist you work with and saying, you know, I know this device is out there, I know it's available, what can we do to help you get the training to be able to use it? And the training really involves just being able to set the right level of that background noise so that it's customized for each individual. Yeah.
So you were talking with those folks yesterday.
I did.
How are we doing in the province with our level of training of speech language?
You know, I think like all of our world, you know, Parkinson's disease is a bit of a strange beast for us as speech language therapists. we were all trained to work on voice, we were all trained to work on speech, we weren't trained on a lot of these other communication dynamics. It's really only been, even theoretically, the last 5 to 10 years that we've come to this increased awareness. I think we're getting there. I think Canada is better set up than some other parts of the world, but certainly the US is probably a bit ahead of us because that's where a lot of the research is done. I don't think we're in bad shape. I think there's an eager desire to learn. I think with now having the availability of some therapies that aren't so resource loaded and resource demanding, we can now convince administrators and hospitals that it's worth doing more investment in seeing people with Parkinson's disease. You might imagine when we think the only therapy is a therapy that requires an SLP's time or speech language therapist time 4 days a week for 4 weeks, it's hard to pull that person away from the basic acute care services that they're required to do. And so that, I think, has been a limiting component. At least I know when I was still working in the hospitals, that was a limiting component. So I think as we move towards some of these alternative delivery methods, we now need to go back and advocate with hospital administrators to say this is important. It's not only important for that, it's important because we expect the population of Parkinson's disease to double by the year 2030 in Canada. This is going to become a massive beast for us to deal with on a health scale. So I think we just need to revisit that. But I don't think we're doing badly. I think the desire is there. I think the interest is there. Now we just need to get administrative support to allow the SLTs to do what they can do. Yeah.
Okay, thank you.
Any other questions? Yeah. Why don't you use your twice as clear voice and let's see what you can do without it.
I play a musical instrument, and
Yeah.
I find that in the past couple of years, I've had trouble with intonation, going sharp, going flat, and controlling that, recognizing it. Is this a part of the Parkinson's?
May I ask what instrument you play?
Trombone.
Trombone. Okay, I assumed it was a wind instrument of some kind. It could be a component of respiratory support. You have to remember, again, it's not, I mean, my knowledge, I played the flute and then I switched to the cello, so I just got rid of having to use my wind for things. I went to using my hands. But at least my memories of playing around with those types of brass instruments is that it takes very fine control of the mouth as well as fine control of the respiratory system to keep those notes exactly where you want them. And my guess is what you may be experiencing is some of, again, that scaling effect or that control effect in terms of not being able to get your respiratory system just right to either hit that sharp or that flat component. I think that's interesting, and I would, there is the possibility that even working with a music therapist, and those folks are around, who can help you maybe come up with very specific strategies around how to use your breathing differently or how to use your mouth shaping differently given the changes in your Parkinson's disease to be able to maintain that. I think it's important. I thought what you were going to raise, and I have a colleague at Northwestern University who's starting to do some brilliant work, and she's pulling me into that work around rhythm. And how musicians, one, have a less likelihood of developing dementia. Musicians, because music is linked and rhythm is linked to language. And how rhythm itself and maintaining that musical instrument playing actually helps your brain pathways to be better connected than other people. So I would say don't stop playing and maybe consider engaging the help of a music therapist to help you really fine-tune those strategies now around your Parkinson's disease. I dare say it's probably the Parkinson's disease, and again, just some of that scaling piece. Yeah. All right, so thank you so very much. I'll be around kind of through the lunchtime hour and happy to take any other questions, but thank you again.